about tools, frameworks, workflows to try and enhance transparency and reproducibility, particularly focused on pharmacoepidemiology studies that use large healthcare databases. Using the buzzword terms, these are also called real-world evidence studies. And we've had a variety of reactions depending on the audience. Given that this is metrics, I think you've already drunk the Kool-Aid, and so we're preaching to the choir. But I recently gave an academic lecture where the response was very defeatist. They heard us talking about a lot of tools and things that they can do to try and improve transparency and reproducibility, but it was overwhelming. It was too much to do, and particularly in today's impossible funding environment. So what we thought we would do is in the first 15 minutes of the session, I'm just going to run through a brief presentation that goes through the reasoning sort of that we'd like to use to try and motivate those who are on the fence. For those of you who are already converts, maybe you can use this reasoning yourself in your conversations with others or offer us feedback as spectators. Does this adequately address the pushback that you have heard from other people? And then after this 15-minute presentation, Anton is going to present more specifically on current tools and how his group has incorporated them into their operations. Okay, so for this opening 15-minute mini lecture, I'd just like to talk about moving toward a better approach for real-world evidence studies through the lens of the why, how, what golden circle framework that was proposed by Simon Sinek as a model for inspiring change. So I'll start by discussing why a better approach is needed, move on to how to differentiate high from low quality real-world evidence studies, and then what can we do to improve. But starting with why. We need a better approach because of the all too common situation that we find ourselves in, where there's poor quality or conflicting evidence from real-world evidence studies, meaning that decisions may be made based off of flawed evidence, public health does not improve, and the credibility of real-world evidence and science at large suffers. There's many examples of this in the peer-reviewed literature. For example, we saw this with high-profile surgisphere studies that had to be retracted during COVID. And this sort of thing happens not just in those really high-profile retractions, but a few months ago, or actually it was more than a few months, it was about a year ago, last fall, in a major cardiology conference in Europe. There was a session that was really focused on the hot topic of neuro GLP-1s and cardiovascular outcomes. And in this session, there were two back-to-back presentations. First up, there was an Eli Lilly study that found huge cardiovascular benefits of tirzepatide compared to semaglutide after projecting out the 10-year cardiovascular risks for both drugs. Next up was a study from Novo Nordisk, a real-world evidence study that found the opposite, that there were huge benefits of semaglutide compared to tirzepatide on the same cardiovascular outcomes. Now, these are back-to-back presentations in the same session, and the room became uncomfortably quiet. I'll come back to this in a moment. So clearly we need a better approach. And the question is, what guardrails can we build so that public health can benefit from decisions that are based only on rigorously conducted and robust real-world evidence? Going back to the golden circle, let's talk about how to differentiate high quality from low quality real-world evidence studies. So the building blocks of transparent and reproducible research are consistent across disciplines. We basically know what we need to do. Develop a clearly specified protocol, pre-register it, provide information on data quality and how to access it, share our analytic code, and also follow reporting guidelines. While we have the tools, the challenge is really integrating them into our everyday work. Because change is only going to come when people set collective expectations and take action. So one way to help shape expectations is to make them visible. Anton and I have borrowed from the Open Science Framework a model for a structured transparency statement that explicitly declares the level of transparency that has been achieved for each of the building blocks in open science, where with higher levels of transparency, an open science badge can be earned. So these badges allow research teams to proudly display the open science practices that were used, and every researcher who uses such a statement sets an example for transparent and reproducible science. So taking examples from our own work to show the evolution in terms of transparency for ourselves over the last decade and a half. This is an example of a statement that would have been written for an early study. This study was not pre-registered. The protocol is available upon request. which is code for "you're never going to see this protocol." Neither code nor data is available, and we didn't look at a reporting guideline when preparing this paper. A bit further into our careers, here's one from Anton, where the study protocol and amendments were pre-registered in the EU PASS registry. The code and the data was not available, but the record reporting guideline was used in preparation of the manuscript. And here's a more recent one where the transparency statement says that the study is pre-registered on the RWE registry with the initial protocol as well as amendments. The code is available on GitLab, and here's the link. The data can be accessed by applying to the Danish Health Authority, and here's the link along with details about how to apply it for access. And the record reporting guideline was used. So going back to that recent awkward silence in the cardiology conference, there was actually a third presentation after the Eli Lilly and Novo Nordisk presentations, which was given by my colleague Niels Kruger. He presented on his work that was just published in JAMA. He was also interested in investigating the question of cardiovascular effects of semaglutide and tirzepatide. And his approach was to start by doing cohort studies that benchmarked against reference RCTs that compared semaglutide to placebo or tirzepatide to placebo. He then expanded his populations to reflect clinical practice populations, and then he did a head-to-head comparison. He used the Harper protocol template to enhance the reproducibility of real-world evidence studies. The protocol was pre-registered on clinicaltrials.gov. Amendments were documented contemporaneously. The analytic code is available on GitHub, and information on how to acquire data access with the data vendors is provided. So what he observed was that using his design, data, and analytic infrastructure, he was able to successfully benchmark the results of his studies against placebo-controlled trials. And the results showed large benefits of both drugs compared to placebo that was similar in expanded populations. And then when he moved on to apply the same design, data, and analytics infrastructure for the head-to-head comparison, he observed that the magnitude of benefit was similar for semaglutide and tirzepatide. So what do we do in the face of conflicting results, and how do we differentiate? A first step is transparency from protocol to publication. But it's important to keep in mind that transparency is not the same thing as study validity. You can have a highly transparent study that is fundamentally flawed, but you may not be able to identify those flaws without transparency, as you can see in this 2x2 table. So as a first step, what we need to do is routinely incorporate the building blocks of transparent study conduct. Because if we don't, we're stuck in the bottom 2 cells of this 2x2 table, where we're unable to differentiate the high-quality studies that we do want to use to inform our decision-making from the low-quality studies whose evidence we want to disregard. But by increasing transparency, we give ourselves the tools and the information that we need to focus our attention and our resources appropriately. Going back to the golden circle, the last topic for today is what we can do to improve. So there's many stakeholders in the research ecosystem, from evidence generators to evidence consumers, and we need multiple layers of engagement to prevent misleading evidence from misinforming decisions in the public. There's no single entity that is free of weakness. But the Swiss cheese model of error is a great fit here, where key stakeholders, including decision makers, journals, conferences, and academic or workplace training, can provide multiple layers of defense against poorly conducted real-world evidence studies. Decision makers have been hard at work creating their own layers of Swiss cheese, with over 50 guidance documents released in less than 10 years. And there's been a consistent focus throughout these guidance documents on transparency and reproducibility, as well as a shared concern about design decisions that are driven by knowledge of the results. So the ask has increasingly been for early engagement and pre-registration of clearly specified protocols. The Harper protocol, which I mentioned before, is a protocol template to enhance reproducibility of real-world evidence studies. And it's one that's been widely endorsed in guidance for regulatory submissions, including recommendation in the ICH M14 guidance that affects both the US FDA as well as other global regulators. There's also been recent guidance from the Centers for Medicare and Medicaid Services asking for submitters using real-world data to use Harper as well. It's also been endorsed by many other global stakeholders. Journals also have a role to play. For example, the Society Journals for ISPE and ISPOR have both updated their author guidance to strongly encourage the use of transparency statements with open science badges, and we're currently in discussion with major medical journals to do the same. Conferences are another place that can help shift cultural expectations. For example, by asking presenters to include transparency statements with the badges on the posters and oral presentations. Now, ISPE piloted this last year in their August conference. It's going to be live this year as well. And ISPOR is also looking into incorporating this into their Vienna conference. When you're at a conference and you see other presenters with these statements and badges, it may help prompt more researchers to think about incorporating these practices into their own everyday work. Now, it does take time for change to happen. There's many questions that are common across organizations, like what will the verification process look like, and who will be responsible for verifying that the statement is true or that the links are real. But the good thing is that we as a community don't have to wait for requirements to get started. The tools are there, and you can be an innovator or an early adopter to help set expectations, while there may be other groups that are slower to change or will have to catch up. So in terms of training, the building blocks of transparent study conduct can be built into academic and workforce training. Early career researchers can give some of these tools that I mentioned a try. And supervisors can model transparency for their teams, reward it in peer review, and also ask about it in the next team meeting. However, as I mentioned, we have heard some pushback from academic researchers about how this is all very well and good in theory, but doing all of these things to promote reproducibility and transparency will be a lot of work. There's been budget cuts, funding is dried up. Given the limited postdoc time you can cover, why direct it to these activities instead of getting out another paper? So I want to tell you about a few early adopters. These are photos of two of my close collaborators. Both are super rock stars. So Will is a practicing pulmonologist who, after many years of clinical practice, joined Harvard as a fellow in 2022. He wanted to do pharmacoepi work in the respiratory clinical area. I was a mentor to him on his K Award, where he showed early interest in implementing transparent and reproducible approaches. Today, he has over a dozen pharmacoepi papers published in top journals, such as JAMA, Annals, BMJ, and Health Affairs. Now, how did he achieve his productivity? Part of it is that, as I mentioned, he's a superstar. Another is that we spent a lot of time laying out the groundwork for his portfolio. By this, I mean developing code sets for phenotyping patients, or defining key parameters like exposures, eligibility criteria, etc., that might be of particular interest for the COPD and asthma patient population that he was interested in studying. For his first protocol, we went back and forth many, many times to get all of the details of design, measurement, and analysis as clearly specified as we could, and we spent a lot of time working to get his implementation workflow set up in a reproducible way. But after we had that set up, Will was able to reuse, tweak, tailor his vetted and tested infrastructure for each subsequent study, leading to an exponential increase in his efficiency for turning out papers that were able to address clinical and policy issues in a timely way. So all of Will's study protocols are pre-registered on the RWE registry. The registrations include fully specified Harper protocols. All code algorithms are provided in the appendix, and amendments to the protocol are documented in real time. Another super rock star is Niels Kruger. He trained in cardiology and data science in Germany, but decided not to practice clinically. He was really interested in RWE, but didn't have much experience, so he joined my team as a postdoc. Like Will, he spent about 6 months developing his first protocol and code sets, but for him, these are focused on the cardiometabolic space. He spent another 3 months developing his reproducible workflow and analytic code with version control on GitHub. His first paper was in JAMA. This was the one that I mentioned earlier, where there was conflicting evidence from different groups. And I found it interesting to note that one of the reviewers of this paper was someone who was clearly suspicious of real-world evidence, making statements about RCTs being the only valid way to avoid bias. But this reviewer sort of begrudgingly said that if someone were going to do a real-world evidence study, the way that Niels did it was at a much higher level than most. And since then, Niels and other members of our team have received favorable comments from journal reviewers at top journals about how we have transparently pre-registered our protocols with documented amendments and shared code. So it's something that they're taking notice of, and something that makes us stand out in the crowd. And so a few months later, Niels published a related paper in Nature Medicine, and he's continuing to take up the same track as Will, with an exponentially increasing efficiency in developing new clinical questions, turning out protocols, and each time he's pushing the boundary a little bit, trying to ask a more challenging question, requiring a slightly more complex design or analytic plan. But it's all built on that core infrastructure that he's built, with modular changes in a section or two to tailor to the particular question of interest. So a take-home message is that transparency and reproducibility is not just good in principle for science and public health at large, it's also an investment that you make in your future self. When you implement these practices to make your work transparent and reproducible, and when you and your teams are sharing amongst each other or between research groups, It creates reusable infrastructure and greater efficiency both for you and for everyone else. So as JFK said in a speech in 1963, a rising tide lifts all boats. So that, in a nutshell, is a why, what, how summary for moving toward a better approach for real-world evidence studies. And with that, I'll turn it over to Anton.
Thank you. Let me see if I can also figure out how to share my slides and see you at the same time. That is much preferred. So I am clearly Shirley is the brain about behind all of this operation. So I'm sort of the muscle in front type guy, and I will now do a more sort of a practical thought on now what to do about all these aspects. And to do that, I need to not introduce myself, but at least introduce my team, because we've been doing pharmacoepi for, I guess, technically 37 years or something in our division, and I've been involved in building a large operation for the last 12 or so years. So I'm based at the University of Southern Denmark. We are more or less specific to pharmacoepidemiology. There is a bit of qualitative stuff. There's a bit of healthcare utilization in general, public health research, but it's mostly registry-based pharmacoepi. We are a reasonably large team. We were 5 people 14 years ago, and we are 48 people now with 8 job postings, making us 50-something in a little while, which also means that I now have the muscle to discuss infrastructure and build into some of the workflows, the stuff that Shirley just mentioned. For instance, we have 6.5 dedicated programmers across the unit by now. And so I very much know the potential criticism that comes with arguing we need to do this, because a junior researcher will typically say, well, that's just wonderful. However, this is way too time consuming. But now that we have a bit of experience, we've done some of these practices for a few years, we can confidently support the hypothesis provided by Shirley that this is actually time consuming upfront, but it is time saving net. We have other processes that we typically say this is actually time consuming, time saving even within the first study. That's not it. This is not the situation we are in here. It does require a year or 2 for most if this is on an individual level. But surprisingly, the time frame isn't much longer on a group level. So within a few years of having initiated all of this, I very much see processes speeding up. That is not to say we publish more papers than we used to do, but that's a completely different story about how we are trying to do more impactful and heavy hit ones with the time freed up. It's not about churning out necessarily more papers, but it's about putting a lot more effort into the single one. So I am now trying to herd 48 conservative cats. That is how you work with academics. They very rarely do as told, which is one of the wonders of being a manager of a science division. But I need to do something. And one of the few things that I've done, I want to show you. For instance, we have an internal queue system. Of course, if we are to do a study, we need to make sure that someone checked whether we have the relevant approvals for accessing the patient data that we are accessing. That's, of course, something we need to have in place. So we have a system where you need to sort of sign off the fact that you checked this aspect. As you can see here, this is from our internal registration form. We now have a requirement of saying you need to, once you've checked the data ID and this RWE approval as data access approval, you also need to note whether you pre-registered your protocol. And if you did not, you need to have a senior go like, it's okay, you don't have to. So it's an opt-out situation. It's not, you can add it. You have to have someone say, okay, for you to not do it. As a rule of thumb, we have said anything that evaluates a hypothesis, you need a very strong excuse as to why not to pre-register. But in fact, I do believe we are about now most of even the descriptive stuff is getting pre-registered because it's just part of the routine by now. I'll show you an example in a little while. Another example is that we have now talked to our programmers over and over again about they need to make sure the code is up to a certain quality level in terms of commenting and structure and niceness. if you've ever tried inheriting or just scrutinizing code done by someone else, but you realize that sharing code is completely worthless. It's typically 20,000 lines of spaghetti, and then you have to figure out what means what. Unless it's Jesper Hallas, my colleague who wrote it, then it's a haiku poem. Everything is abbreviated into sort of a complete cube of something that turns out something that is probably right, but he's the only one able to decipher. In that process of making them do annotated code, it suddenly turned out to be much more reusable, because if you clean up your code and do the annotations, you can remember what you did next time. It's much easier to share, which in turn meant that suddenly it was about time to build the epicor. Epicor is a common data model in a very simple one of that simply specifies the prescription date is called RX date. The date of hospital admission is called ATM date with lowercase atom, etc., so that we make sure all new data is cleaned and presented following the exact same structure. Because suddenly there was much more value to this, because now the code, we had a bank of code that we could reuse given the data followed the same structure. Suddenly, this is now a matter of having collaborators in Norway and Sweden having their data in the same structure, which means that we can distribute code, we can review each other's code, or even just downright reuse code across collaborators. We now have data sets in Norway, Sweden, Denmark, of course, the Netherlands, UK, South Korea, and a few others in the epicor format for various collaborative projects. So just two very specific examples of internal consequences of having championed this. Again, in the very practical space, I want to follow up on Shirley's presentation of the transparency statement. What does this mean in practice? So Shirley showed you these examples of some of the, let's say, initial papers, mid sort of trajectory papers and late papers that we sort of in the paper presenting the statement went back and restructured or reanalyzed how did they do in terms of transparency. But now it's a standard thing that in all our papers, this is just an example on a very large multinational study on GLP-1 receptor agonist and thyroid cancer. In the paper, in the methods section, we now have an explicit statement saying study transparency, sometimes study transparency reproducibility, and we explicitly comment on these 5 domains. Actually, I have colleagues that now started to expand on this, adding in, we actually have internal code review. So the code was reviewed by an independent programmer before submission. We have a rule, you cannot submit a paper before someone else validated your programming. This is an obvious extension, so they just started adding other measures or advances towards transparency or reproducibility to the same section. This is an example of something they added here. As you can see, the source code is available at X, because we would have a GitHub link here once the code is final, but it hasn't been validated yet. As you can see, there's a manuscript under preparation. But they have added this validated internally by data manager as one of the things they would like to contribute. This is, by the way, a purely descriptive study, but the junior colleagues, typically more into open science matters, junior colleagues felt it's just easier to just do this across all studies, not only hypothesis evaluating ones. The pre-registration is a particularly, I think, interesting topic. Or particularly interesting in terms of how the conversation is and has been around open science practices. This is a scoping review made by some of the people from the Nordic Cochrane Center, and they have looked into various databases. This is just the Chinese clinical trial registry showing a clear increase in the number of observational studies registered in this particular registry. Of course, the number of studies are also increasing, and the overall proportion being pre-registered, while increasing on a, I guess, relative scale, the absolute increase is completely negligible. This is not done systematically at all. An interesting aspect in this paper that I really liked was they went back and looked at the discussion about pre-registration. Because this is the number of papers published and whether they were for, against, or neutral in the question of whether you should pre-register your observational study. I think quite many within the field of pharmacoepic remember the debates in 2010 until 2014 with some quite high-profile arguments saying we should not do this, this will kill scientific curiosity, etc., etc. And there is still a sort of a lingering effect of these papers have squashed a bit of the enthusiasm. As you can see, the debate is dying out, and most of more recent papers are actually for pre-registration. So I think this is something that will happen. We recently published this commentary in PDS, trying to map out what can you do practically, because while we have a handful of old geezers discussing this sort of how this could potentially impact stuff, from a practical point of view, what do you do if you want to pre-register your study? And practically, you have three options. There's the Real-World Evidence Registry via the Open Science Foundation. There's the EMA catalog of real-world observational data sets and studies. It's a horribly long title. And then the clinicaltrials.gov. Clinicaltrials.gov is, of course, the most well-known one, but it is certainly not the one most suited for an observational study. So if you've ever tried registering an observational study in clinical trials, there is a few frustrating moments trying to figure out what to put into where and how to get past mandatory fields that makes absolutely no sense. The paper lists some of the properties. I won't say pros and cons. It's more like properties of the various options. For instance, the embargo feature, which is a very important one for the industry partners mostly, but also paranoid academia. If you would like to have something registered but not make your protocol public, I've never used the feature. I don't quite follow, but it is possible in the RWE registry to embargo, not in the two other sites, as an example. Yeah. One particularly important thing about pre-registration, and I think the key argument we need to push, is the fact that amendments are not only allowed, but they are expected. I've been doing this for 15 years or something like that, 17 years. I have published 400 papers, original pieces in this space. I always need an amendment because there's always something I didn't get. Maybe I wanted a comparator that turned out to be too rare. Maybe I misspecified a diagnosis code somewhere. There's always something happening. But I don't quite get how I can make this sort of argument come across. So I've tried all various aspects of trying to sort of emphasize this, making this sort of blink in the eyes of whoever discusses this. Amendments are expected. Amendments are absolutely possible across all these sites. You need to make amendments. I don't think an amendment is a flaw. I just need to know where you started, and I know where you ended, and I want to see the steps done in between. So as an example, this is before we had the transparency statement. This is a paper about COVID in children. Actually, it's 4 papers about COVID in children that we squashed together into one monstrous publication and got into the BMJ. At the point, we only used the usual fine print towards the end of the paper to discuss data sharing, etc. I much preferred having it in the actual paper in its own paragraph for obvious reasons. But as an example, we shared the analytical code, and this was registered before commencement of statistical analysis. And there's also, commencement and amendments are also available at this site. So this is the site that we are talking about, and I'll give you an example of this specific one. So this is how the site looks like nowadays. And for instance, I mentioned the currently ongoing descriptive study, which is, I think, this one. So even though it is a descriptive study, they have made sure to provide a final protocol here. Also this one. The example I gave before on the pediatric SARS-CoV-2 infection, there is a final protocol down here. And ideally, I would like to have the amendments in the same place, but for technical reasons that I have given up understanding, you have to go to the overarching project. And in the overarching project, we have then, of course, listed the 3 final amendments, which is, at least, and that's my preference, not a completely new protocol with track changes or the like. It is a brief list of, we have 4 things we did differently. Well, this is probably not the best one to take. There's a few things we've done differently, and this is the reason why we did this differently, and this is a specific impact. So reasonably short documents, as you can see. We did not have this diagnosis code, but it then suddenly popped up during study conduct. We now use this instead to define this and that. So how to further the agenda? As evident, Shirley and I are giving a gazillion talks on this, and we are very much sort of trying to initiate or at least further the conversation on this topic. Some of the things that we have provided is this one, 10 must-read papers I've tried to select the 10 papers I find to be a good primer for people getting interested or perhaps wanting to teach this to other people. So here's a list of 10 things that cover basic aspects of this, of course, with references for each of them, spanning the documentation that this is not necessarily inherently a reproducible science. Of course, this is Shirley's very large repeat initiative that I know she's presented to you guys before, all the way down to record PE reporting guidelines and the transparency statement. Another very new initiative is the Real-World Evidence Reproducibility report. And I've actually honestly been looking so much forward to saying this out loud, because you are the first crowd we are saying Real-World Evidence Reproducibility report to. We actually have the domain Real-World Evidence Reproducibility report.com, but we realize it's probably better also to have a short URL to get into it, because this is actually a website, the Real-World Evidence Reproducibility report. So in all of this, we are trying to build resources, and I think starting today-ish, we will have this site as part of hosting new resources. This includes a newsletter, which we will distribute the first newsletter tomorrow or Monday or something like that. We have a DNS server issue we need to fix first, but once that is done, the first newsletter will actually air. So I hope you will sign up. The DNS thingy makes the sign up mail more likely to go into a spam folder, so please check your spam folder. There's also a transparency course, which is a 2-hour introduction to all the practical tools. One thing is the introduction stuff that we just mentioned, but also what are design diagrams, pre-registration, code list sharing, reporting guidelines, etc., etc. So as to make it hopefully quite easy to get into this agenda and have input to whatever aspect of transparency and reproducibility that you're very enthusiastic, in particular about hopefully starting the conversation more broadly with the newsletter. So we hope to see many people sign up. This is it. Sarah has promised us you are a talkative, high energy crowd. So for that reason, we have cut it short to make sure we have plenty